I was asked to talk about the management of post-thrombotic syndrome and the role of endovascular stenting. I have no disclosures here. And post-thrombotic syndrome, as you know, is a chronic complication of a DVT of really any extremity. But for the context of this talk, we will be focusing on the lower extremity PTS. It usually develops within the first 2 years in those who had symptomatic DVT. And the recurrent DVT is the most important risk factor of developing PTS itself. There are a lot of scores that we've tried to employ in order to quantify the effect on quality of life and the clinical effect on patients. But I think the Villalta score is probably the one that checks most of the marks that we look at. And is the one that we use mostly when we get post-thrombotic syndrome. A high Villalta score at 1 month has been associated or predicts a more severe form of PTS. The mechanism of PTS, as you know, is essentially venous hypertension, and this could happen in both by 2 ways. One is outflow obstruction, and the second one is an incompetent valves, which happens in regular varicose veins of the superficial system. Or the ovarian veins in case of pelvic congestion syndrome. And one of the non-thrombotic causes that we tend to pay more attention these days to is the May-Thurner syndrome. This is a clear picture of what is called a recanalized vein, and you can see a lot of synechiae and occlusions and a lot of webs inside the vein that's not entirely healthy. Historically, iliocaval reconstruction was employed to treat all sorts of venous obstructions, venous outflow obstructions. Used to do surgical iliocaval reconstruction directly with grafts unilaterally, or we would use bypass from one limb to another in what we call a Palmas bypass or procedure, which is the one in the middle, with or without an arteriovenous fistula to maintain the patency of it. And the goal, again, of this reconstruction was to reduce the morbidity of PTS that happens with it. And the results have been modest. And as you see, most of the studies happened towards the turn of the century, and there are small case reports in series. Their patency rates range anywhere between 50 to 100% as they were reported. The crossover bypasses, the Palmas procedure, whether with a vein or with a graft, again, higher number of limbs and people, higher take-ups to try to bypass a single limb of DVT. And this has been used for both thrombotic and non-thrombotic diseases as well. And the results, again, have been kind of modest, and the clinical improvement is probably good at best, but the cumulative patency is anywhere between 70 to 75%. But the question remains is, why do we do these big procedures for reducing a morbidity or a quality of life? And with the rapidly changing specialty and field comes the endovascular stenting approach in treating those. And the justification to treat this at all, either for open or endovascular, is basically it's a non-lethal disease, and the quality of life is the only thing that we're trying to improve here. It's got some morbidity, but the limb loss risk is very minimal. The prophylactic therapy for silent lesions is probably not indicated, and that happens essentially when you do a CT scan and you find a compression of the left iliac vein, for example. And you think it's a May-Thurner syndrome. As long as it's asymptomatic, it really is hard to justify any therapy for that. The other indication is the failure of compression therapy, which happens in about half of the patients in general. So what actually are the indications that we try to stratify patients and decide whether they would benefit from therapy? Again, with a big title as a quality of life improvement. So if the compression fails, if there is active venous ulcerations, or if there are symptoms related to pelvic congestion syndrome when other etiology have been excluded and the lesion is deemed significant. And again, this significant is is put in quote and quotes because determining what's significant is very variable between clinicians and people who treat this. The evaluation of the lesions is done by multiple modalities. The gold standard, or at least used to be, is the direct venography, which is an invasive procedure that requires multiple views to try to visualize the lesion. It's less accurate sometimes in identifying the ends of the lesion, and that's the proximal and distal ends, and it sometimes underestimates the vein, the actual vein diameter, given the lesions in it, the whips and the synechiae. Others we employ, including duplex and CT venography and MR venography. They can measure lesions. We cannot use them at the time of treatment. And what we could use essentially the intravascular ultrasound, or IVUS, which is very good for diagnostic procedures. People advocate now that it's very essential even in therapeutic procedures. It could identify about 25% more lesions than what venography can identify. That's what IVUS enthusiasts claim. It could correct or correctly identify the ends of the lesion, and this is probably where it's superior than venography when it's employed in the diagnostic and therapeutic procedures. This is how it looks like. It's very important for ideal stent sizing and placement, because wrong sizing is a very, very difficult problem to treat. And this is an example of it. As you can see, at the top arrow, there's about an 88 millimeter stent that was deployed in the iliac vein. And you can see the difference in the diameter between that segment and the femoral vein, which is about 12 or 14 millimeter in size. And that definitely is an iatrogenic stenosis that will be very, very difficult to treat, whether with endo or open therapy. The results essentially of endovascular stenting has been coming up in larger case series in non-randomized trials and single arm experiences. The early thrombosis is very low, and it's a little higher when it's PTS, because most of the studies report treating May-Thurner syndrome or non-thrombotic lesions. The late thrombosis occurs in higher percentages. All of those are PTS. And it was thought of as the stent-related outcome appears to be really associated with the presence and severity of thrombotic disease, and not necessarily the extrinsic factors. And that probably is concluded because of the findings of late thrombosis that only happen with PTS and not non-thrombotic causes. The clinical outcomes, the stent outcomes related to its patency, as you could see, the secondary patency and assisted primary patency can keep the stents open, or can treat it when it occludes with a good degree of success above 90%. And the primary patency goes really down as you go further along in time. And that gives you an indication that this requires a lot of maintenance and follow-up and surveillance in order to maintain the patency of these stents and prevent the recurrence of symptoms. This is divided basically based on the indications, whether it's occluded or not occluded at the beginning, and whether it is a non-thrombotic versus a thrombotic cause. And as you see, the ones related to thrombotic lesions, especially if they're occluded, their patency rates go down to about 50% or even less. These are the publications, the early publications that were published. There are very specific ones that talked about specifically about PTS. The number of limbs, again, higher case series. The secondary assisted primary and secondary patency rates go a little higher, and the time of follow-up goes higher up into the 4 and 5 years. This is for the femoral iliocaval, so proximal stenting in limbs with obstruction in general. The cumulative rates of instant restenosis, as you can see, the thrombotic events are associated with higher instant restenosis, as we described. Is probably related to the degree of thrombus, or the thrombus burden, as we call it. When we go to the clinical outcome, the cumulative complete relief and improvement of pain and swelling after stenting tends to be very, very variable. The complete relief of swelling, again, is very subjective. But again, we're using a few scales for follow-ups, whether it's the Villalta or the visual analog scale or others. This one here, visual analog scale was employed, and swelling is improving up to 60%. Pain is getting much better results with the stenting. When it comes to ulcer healing, it usually happens really early during the after therapy, especially in the first 3 months. And that's because of rapid or remarkable decrease in venous hypertension, which tries to relieve the skin from all the swelling around it and improves the chances of healing the ulcers. The recurrence-free rate is about 60% at 5 years, and it stays modest from the first 3 months up to 5 years, which indicates that the first few months are the most important points, or the most important months in treating the ulcer. Again, recurrence is really, really late in this group. However, the knowledge gap really exists when it comes to treating patients with BTS with endovascular stenting. We lack any meaningful data when it comes to hemodynamic assessment. There are a lot of clinicians and interventionalists who use the pressure gradient, but that has never been proven to be associated with better clinical outcomes. We don't have standardized perioperative anticoagulation. It really is it's an evidence-free zone when it comes to what to use with anticoagulation, whether pre-op, intra-op, or post-operatively. The surveillance guidelines are really dependent on the center, the clinician that's treating this. The outcome measures and scores, we don't have anything that's been universally or at least appropriately validated to treat this. And we don't have it, aligned or compared to other modalities of treatments, whether it's compression alone or even surgical treatments. And the cost is a big, big deal when it comes to the endovascular stenting. Here are examples of the stents that we are or have been used. And as you see, more or less the primary effectiveness endpoint, or primary endpoints of all the studies and the trials that these stents were used are mostly single arm: the Vici, the Zilver, the Venovo, the Aubrey, from different manufacturers. Most of them focus on the freedom-free reinterventions, the occlusion or the instant stenosis, which is, again, despite being done by duplex or venography, is again an operator dependent. Venovo and Vici have been approved and published since 2019. Aubrey, we're waiting for the results to come out clearly. Zilver, I don't think we have good representation of Cook here in the country, so Zilver is not really floating around in the market here. However, Venovo has been actually recalled because the proximal end of the stent does not immediately expand upon deployment, and it still remain attached to the delivery system, which has been reported in a few instances, and it really is problematic when you try to manipulate the delivery system to try to get it off, because that could result in a lot of injury and trauma, local trauma to the vein, and increase the thrombosis risk. Vici was recalled as well. They migrate, probably related to the sizing, but they have been migrating, and there have been complaints reaching more than 240s, 250s. They migrate from where they are initially implanted in the femoral or iliofemoral or iliocaval segment, and when they actually land in the heart or the lungs, it's actually very, very problematic and could be a life-threatening injury. The same thing could happen when treating central venous occlusions at the top in the vena cava. Some of these stents end up in the pulmonary artery, and that could be life-threatening as well. And again, all these stents have been studied mostly in a single arm or against placebo, and we don't have really solid or sound randomized controlled trials to treat this. And I would argue that this is extremely important. However, it may not be a hot topic, and I wouldn't expect it to be done or funded properly by non-industrial funders. So in summary to this talk of role of endovascular stenting in treatment of BTS, it's done primarily to improve quality of life, and most of the studies are single arm and have mixed patients between thrombotic and non-thrombotic causes of treatment. They appear to be generally safe and durable for selected group of patients with proper surveillance and ongoing follow-up. Improved stent technology enhances therapeutic options, and I put a lot of asterisks there just because as more stents come out, like the Vinovo and Vici, we were very enthusiastic and very excited to see their results when they came out. Yet they have been recalled very quickly within less than 18 months. And so perhaps careful progression in this regard is advised. IVUS may be superior for these procedures just because we could use it in diagnostic as well as therapeutic procedures. However, it's very costly and it's very limited in its presence in the institutions. We don't have good follow-up hemodynamic measures. We just measure it really by the in-stent stenosis when it comes to venography, and we don't really know the numbers when it comes to the hemodynamic numbers or the gradients, whether or not they're important clinically. All the stents have showed good to great clinical outcome, but again, these studies have been observational at best, and we really need randomized trials in this regard to try to help us decide whether this is the best treatment for such patients. That's all what I have for this, and I'll be happy to answer any questions.